Well, good morning and good afternoon to everyone. Welcome to today's conversation. I'm really glad that you're able to join us. We know it's a busy month and a busy day, so really thank you for joining us today. So today's discussion, as you know, we'll be looking into how local governments and donors together can build resilient health financing in the wake of COVID-19. And the crucial role of civil society in creating and sustaining that subnational fiscal policy. I'm Suneeta Sharma, I'm the Associate Vice President for Government Relations at Save the Children US, and I'll be moderating today's discussion. Before we go into the substance, I just wanted to start off with some housekeeping items. Please keep your microphones muted unless you are speaking, particularly as we hear through the panelists' presentations. This is supposed to be an interactive discussion today, so we do encourage you to use the chat box or Q&A feature at the bottom of your screen to ask questions, or if you have comments or flatlining or decline of official development assistance or ODA. And we're now even seeing an increasing, donors are increasingly turning inward because they themselves are also trying to address the pandemic and cutting aid budgets or lowering the quality of aid. Despite the vast needs in many countries. We're also seeing an either-or situation in many countries where they're having to make critical resource choices, addressing the pandemic, purchasing vaccines, addressing the impacts, looking at universal social benefits to help households impacted by poverty, or continuing routine services, particularly in health. And this has led to a pause in routine immunizations amongst children, decrease or challenges of accessing healthcare services for women, such as antenatal or postnatal care, decline in access to nutrition for women and girls. Really highlighting even the need for more increased resources, and the need is even greater now. Even before the pandemic, I talked about declining or flatlining of ODA, and that, coupled with an increased focus on country ownership, has actually led to an increased focus on the role of domestic resource mobilization, or DRM. DRM holds great promise for sustainable own-sourced financing that can be allocated to meet the development needs of a local community. Save the Children is a supporting organization of what's called the Addis Tax Initiative, and we're committed to the goal of increasing equitable, transparent DRM to finance the SDGs. Particularly at the subnational level, we believe DRM can be a useful tool, not just for increasing revenue for development projects, but also for strengthening the social contract between a government and its citizens. Donors can also play a critical role in fostering increased DRM for health, particularly at the subnational level. So we wanted to look into this more deeply. And so with the support of the Bill and Melinda Gates Foundation, Save the Children conducted research on best practices and lessons learned in increasing subnational financing for health in Kenya, with a particular emphasis on the role of USAID and other donors. And you'll hear more about this research in a little bit. This research complements our ongoing work in Bungoma and Wajir counties on governance, accountability, and citizen participation, which is supported by the Hewlett Foundation, and tax policy and revenue allocations for development priorities for children, including health. So over the next hour, building off of our report, Building Resilient Health Systems in the Wake of COVID-19, we're aiming to explore the factors leading to increased health financing at the subnational level, food for thought for the remainder of our conversation. So we'll build off of some of the things that we're going to talk about, and also the panel presentation. So following the brief findings of our report, we're also going to be hearing from experts working with the US government on DRM for health, and rather move right into a discussion with you all using chat, and also giving you an opportunity to come off mute and intervene during the discussion. So now it is my pleasure to hand over to Andrew Wainer, who's our Director of Policy Research and was the lead researcher for this report, who will present you the key findings from the report, which we're looking at Makueni and Nyeri counties. So Andrew, over to you.
Thank you, Suneeta, and thanks for that great introduction. So I'm gonna briefly, as a way to sort of get the juices flowing and get the discussion started, walk through our report, Building Resilient Health Financing in the Wake of COVID-19, Subnational Health Budgeting in Kenya. And I think this will be meshed very well with the presentations from Suneeta and Anne later during the event. So just a quick agenda on what I'm going to talk about, very straightforward. We started this report actually sort of before COVID-19 and did the research during COVID-19 and was hoping when we finished it, COVID-19 would be behind us, but unfortunately it's not. So, I think in talking about health financing, we have to talk about the COVID-19 context and particularly the response globally, the fiscal response to COVID-19. So I want to sort of set that frame as we get into the findings of the report. Then digging down a bit more, this report is very much focused in Kenya and more than that in 2 counties in Kenya. It's a case study report on 2 high-performing counties in Kenya in terms of DRM and PFM for health. So I'm going to talk a little bit about the Kenyan context. Then the heart of the report and our research and analysis is on the 2 counties, Nyeri and Makueni counties. So I'll spend a little time sharing some of our key findings there and the challenges that they're continuing to face in terms of health financing. And then recommendations. Again, this research, as Suneeta noted, was really focused on how donors, citizens, and local and national government in Kenya can work together to make health financing efficient and equitable in an era of COVID and beyond. So in terms of what's going on now globally with COVID-19, about 193 million reported infections, 4.1 million deaths globally. And I thought a few months ago we would soon have this behind us with vaccines coming out, but although 3.9 million vaccine doses have been administered, the vast majority have been in advanced economies with only about 1.1, although that number is going up very slowly. I think the last figure I saw is about 1.1% of all vaccines had been administered in low-income countries. And in Kenya, although it's a lower middle-income country, falls into that range. I think again, the last figure I saw is about 1 to 2% of all Kenyans have been vaccinated. So a long way to go in developing countries in terms of vaccination, which makes the health financing piece even more relevant and crucial today. So there's been a tremendous amount here. I'm sitting in Washington, D.C., and just a tremendous amount of global stimulus, again, in the advanced economies to try and deal with the economic and health effects of COVID-19. About 16 trillion has been spent globally to deal with COVID-19. Governments have pumped 16, his 2030 vision, which is their broad decade-long development policy agenda. And within that agenda, and something that President Kenyatta has really emphasized and made important in his administration, is universal health coverage, which was an extremely ambitious policy objective, and it's been actually quite problematic and has been fallen short. To sum it up in basic terms, has not been effective. And today, only about 17%. That number is different depending on how you cut it, but that even may be a little. We'll get that into that in much more depth. So I'll just kind of touch on it briefly here. But I think as of 2020, about 11.1, just over 11% of Kenya's total government budget goes to health, and that's been ticking up over the years. But it's been increasing, so it is going up, but it's been a slow increase, and it's still below the recommended 15% Abuja declaration goal, which Kenya is committed to. So just also to note that while health funding is increasing, it's increasing slowly. And then a big part of this presentation and our research is the role on donors, and particularly USAID, in working with governments on in subnational, national level on enhancing DRM and PFM. And now USAID, most of USAID's health intervention in Kenya is at the county level. So we can see USAID and others have already seen that counties and subnational work on health finance is really becoming a priority. And I just want to touch on 3 quick challenges before moving into the moving into the specific county key findings from the two counties we researched. One is budget credibility. So this isn't, and I think a panel will also discuss this more in depth, but in 2017, the Ministry of Health underspent the budget allocation by 20%. And so budget execution, budget credibility is an ongoing issue in Kenya. So we talk about more money. I think it's important to have more funding and more resources, but this is why sort of the PFM and the budget work is so important, because if you underspend your previous year's budget by 20%, that's not a good way to get your budget increase the next year. So budget credibility and budget execution is also a part of the whole of increasing revenues. All that goes together. And again, just touching back to devolution, I think devolution has been, from what we learned through secondary research and talking to our research in Kenya, it's been a mixed bag. Devolution has had a lot of good. It's brought, by no doubt, it's brought services closer to communities and citizens, so that they have more of a say, certainly in healthcare and other services on how they're delivered and administered. But in Kenya, the transition to devolution was quite disorganized. And so we had one quote I put here, one person we talked to in one of the counties said it was sort of on-the-job learning. One day there was no devolution, and the next day everything was devolved, and counties kind of had to learn to scramble to administer, to manage health financing at the sub-county level and link that to services. And then finally, that's the last challenge, although the government, happily is increasing more of health financing in Kenya. There's still a large portion of health revenues is through out-of-pocket costs, Kenyan household costs, and foreign assistance. So a big part of this research and the advocacy we're doing, and as Suneeta said, is to really support governments in UHC and paying for more of health coverage, rather than coming out of the pockets of Kenyans and from foreign assistance over the long term. Trying to go to the next slide here. Okay, it was a little slow in advancing. All right, so our first case study county was Nyeri County, and we identified these counties through a reputational sample, both interviewing experts in the field and also looking at data from the World Bank and from actually the Kenyan auditing and oversight agencies that had ranked these two counties high in terms of public financial management and budgeting practices. So some of the effective practices, again, this is a very quick overview, and I point you to the report that goes much more in depth on these two counties. But some of the effective practices we saw in Nyeri, one is was leadership, and that's just simply leadership prioritizing healthcare. And they put their money where their mouth is, in dedicating about a third, 34% of their total budget went to healthcare. I think the average, changes, but among Kenya's 47 counties, the average was about 27% of county budgets going to healthcare. So Nyeri County had a sustained, although it changes year to year, they had a sustained commitment of about a third going to healthcare, which was among the highest of all of Kenya's 47 counties. Nyeri also benefited, and I know we'll hear a lot more about this from Suneeta on the panel, but they benefited a lot from working with USAID's Health Policy Plus project, which I think Nyeri was one of their focus counties on health budgeting, capacity building, particularly aligning their work plans with program-based budgeting, which resulted in addition to other, combined with their good leadership, really high quality PFM for health, including digitally linked facilities, health facilities, so they could address finance and supply issues in real time. And so Nyeri County, I think, was ranked one of the second out of all of Kenya's 47 counties by the World Bank in terms of public financial management, and also was noted for having really strong participatory budgeting practices. And we went there, we met with sort of a cadre, an incipient cadre of fiscal governance, civil society advocates. On the challenges, some of the challenges facing Nyeri were in some ways not unique. They're the challenges that were facing, Kenyan counties across the board. And one was an over budgeting recurrent expenditure. So, a large portion of the salaries went or a large portion of the budget went to salaries, which can sometimes block out or make, not create enough space for budgeting community priorities when all the health budgets are continuing to go to salaries for health officials. Another big issue was intergovernmental transfers. I think again, our Anne from ThinkWell and others will talk about that, but that's a problem across the board in Kenya. That many county experts we spoke with said that they're very still dependent on transfers from the national government, and they weren't always getting those transfers on time to fund the programs they needed in the time and the place that the counties had laid out. So getting the money from the treasury, from the national level to the subnational level stands as a challenge in the area and in many counties across Kenya. So our second case study county, Maasai County. Again, there's sort of just a basic prioritization of healthcare and above the average of Kenyan counties. And just, again, about a third, just under a third in Maasai, 32% of county budget went to healthcare. And that was, again, really linked to the governor of Maasai, who had a broad consultation with citizens, really long and detailed and comprehensive consultation with citizens on their priorities. And he found that, a lot of citizens were having catastrophic health incidents where they would be falling into poverty because of health issues in their household. So they just invested in health. First of all, by, hiring more staff, building more facilities. And once they sort of increased the access issue, created more access to healthcare for citizens, they also had a quite innovative local insurance scheme called Maasai Care that I know ThinkWell was quite involved in. So we're happy to have them on the panel to talk about that more. But within the context of the national healthcare coverage scheme really falling short, Maasai County and the governor there and his leadership team created a county level, really interesting county level health insurance fund called Maasai Care that also helped households be able to afford the increased access that he created through more facilities and health staff. And this was really also done, primarily through the leadership of the county, but also done hand in hand with donors. In this case, primarily the World Bank, which had a longstanding participatory budgeting project, and really helped the Maasai County leadership think through this and implement this in the county so that community voices could be heard and the community health priorities trickled up to the health officials at the county level. And this really strengthened accountability for healthcare at the county level. Finally, this is a change that happening across Kenya at county level, but the Maasai County also piloted the devolution. Again, this goes into much detail in the report, but it was sort of paradoxical in that it really empowered counties, but in some ways disempowered health facilities. Because when decentralization happened, health facilities were much more beholden to leaders at the county level for spending and for budgeting. So they would really have to go through a pretty onerous series of checks and approvals before they could spend at the facility level. So what the leadership in Maasai County saw this and saw that it was inhibiting performance at the health facility level. So they empowered health facilities, giving them more fiscal autonomy so that health facilities themselves had more autonomy and were empowered to collect and spend based on the health services they were providing and the revenues they were collecting, rather than just send that to the county level, and then the county level would decide how to distribute that. And that gives them the ability to collect and spend and implement on a much more timely basis and be more responsive even to the communities where the facilities are. Challenges in Maasai. Again, leadership is crucial, and it's important that these changes are integrated into policy and not just sit with a person, not just sit with a governor. And that's across also in Nyeri also. And then another major challenge is own source revenue. So the counties across the board in Kenya are dependent on the national government, sometimes about 90% of the funding. So there's a real opportunity for counties to raise more money at the local level through property tax and other sources so that they can be less dependent on not only foreign assistance, but national level transfers. So just to wrap up, just key recommendations for moving into the panel, is focused on subnational finance. County health budget allocations increased 178% between 2013. So, as I noted, subnational stakeholders are really some of the main players in health financing in Kenya increasingly. Integrating local civil society networks, this is, that's crucial to combat corruption and elite capture, so that, and to ensuring that health financing at the local level is gender sensitive and includes marginalized communities. And then also a focus on own source revenue. That was something that we didn't see donors engaging as much in. And we think there's the World Bank and others have found a potential for not just to help money flow from the national level to the subnational level, but for counties to raise more funding themselves. So with that very quick overview, I think I'll wrap up and turn it back over to Suneeta, and really looking forward to the panel presentations and discussion. Thanks.
Thank you so much, Andrew. That was a very good and concise overview of the report. Anybody who has questions or comments on the report findings, please do include them in the chat box. I'm going to go right into our panel presentation now. Our first speaker is Suneeta Sharma, who is the director of the Health Policy Plus project for Palladium. Suneeta, over to you.
Thank you, Smita. Yes, so I'm pleased to share with you HP Plus Kenya's experience and approach to strengthening planning and financing in the health sector. Over the past decade, our team has supported national and county level actors to inform policy decisions, strengthen capacity, generate and use evidence in decision making, and support domestic resource mobilization. So the past decade has been great progress in health policy in Kenya. The health sector is governed with the guidance of 3 national pivotal health policy documents. So Kenya Health Law and Kenya Health Policy are 2 policy documents that HPP and HP Plus helped develop and shuttle through the adoption process. They formalize Kenya's commitment to UHC, collaboration between national and county governments, and oblige Kenya to address the health needs of vulnerable groups. In a progressive step, the law also ensures free maternity care and vaccinations for children under age 5. We recently supported the Ministry of Health and other actors to finalize the Kenya Health Financing Strategy 2020-2030. This strategy was developed through extensive consultations and will pave the way for critically needed reforms in the health sector, particularly in expanding USC and reforming NHIF. In Kenya, we see that policy for health financing matters. These guiding policies facilitated additional advancements, such as reinstating a budget line item for HIV commodities in the MTEF, which is midterm framework, expenditure framework, providing MOH with the framework to advocate for abolishing user fee, including fees for maternal and child health services at public facilities. HP Plus worked with Ministry of Health and NHIF to redesign free maternity care program launched as Linda Mama. In addition to supporting counties to implement these national policies, HP Plus is supporting Mombasa and Kilifi counties to amend their health acts to allow for facilities to retain and use funds collected at the health facility as opposed to absorbing them into the overall county budgets. Okay, sustainability has been at the center of USAID's and HP Plus's approach to health policy and financing in Kenya. HP Plus adopted a long-term vision by strengthening capacity in PFM in health to optimize not just how public funds for healthcare are committed, but also how they're allocated, managed, and accounted for throughout the PFM system. In partnership with the Kenya School of Government, we have focused on equipping national and county government teams with manuals, tools, and training modules on program-based budgeting to institutionalize the link between inputs and outcomes and harmonize budgets and other planning processes such as annual work plans and procurement plans. Our assistance to the National Malaria, HIV, and Family Planning Program have fostered an understanding of how to successfully advocate for budget resources and work with the National Treasury, and facilitating exchange on health financing through knowledge sharing platforms such as the Council of Governance and the Intergovernmental Forum on Health have allowed the national and county governments to establish strong relationships and share practices that work. So HP Plus Kenya continued USAID's legacy of supporting Kenya health sector through the process of devolution alongside the Kenya School of Government, the Ministry of Health, and the National Treasury. HP Plus trained and coached over 700 people from countries to develop program-based budgets and align their funding priorities with current need. We then supported counties to harmonize PBB with other planning processes and outputs such as the county annual work plans. So an integral component of our approach is strengthening the capacity of Kenyan experts to generate evidence to inform health sector decisions at the national and county level that will result in increased resources for national and improved health outcomes. From NHA to national and county budget analysis, public expenditure analysis, and county health accounts, HP Plus has supported the Ministry of Health and counties to track, share, and use reliable public budget allocation and expenditure for increased accountability and transparency. The best way to strengthen demand for evidence is to support teams to understand how to use it in decision-making and planning. HP Plus supported counties and the Ministry of Health through on-the-job mentoring to produce several pieces of evidence, including public expenditure analysis, MTEF budgets, the Kenya Household Health Expenditure and Utilization Survey. These data were then used during workshops to identify pain points and issues affecting residents, such as access to health insurance coverage and insurance instances of catastrophic expenditures, as well as inefficiencies in how resources are allocated. Having identified these pain points, HP Plus supported consultative discussions to prepare action plans and how to mitigate these problems, and supported counties to exchange lessons learned and their successes along the way. So through this support to the Ministry of Health from HP Plus and other development partners, we've seen funding expand for health from 7.6% of the total government budget in 2016-17 to little over 11% this fiscal year. These resources demonstrate Kenyan government's commitment to USC and are just the beginning of realizing the Kenya health financing strategies vision for health sector. HP Plus supported the Ministry of Health and county stakeholders to successfully advocate for a total of $89 million for ARVs and related commodities between the financial year 15 and 16 to 18-19, and an additional $85 million line item for ARVs and Kenya midterm expenditure framework lasting through 21-22. So HP Plus provided critical analysis and evaluations to generate over 165 million for healthcare, family planning, and prevention of mother-to-child transmission for HIV. Through this program, over 1.1 million women have accessed life-saving maternal health services with documented increases in facility-based births and decrease in infant and maternal deaths. So at the county level, HP Plus supported 14 counties and with more intensive assistance in 9 deep dive counties through the intensive capacity strengthening assistance and evidence generation. Counties made advancements in DRM. 7 of HP Plus's focus counties committed $5.2 million in FY 2021 to maternal child health, which is like 41% increase from previous year. Deep dive county increased allocation to HIV interventions from $165,000 in 2017-18 to $239,000 in 19-20. So aside from resource allocation, counties documented tremendous improvements in budget absorptions, in reducing out-of-pocket spending, and in reducing the proportion of the budget devoted to personnel. So budget absorption in deep dive counties increased from 79% in 16-17 to 84% in 18-19. And deep dive counties reduced out-of-pocket spending from 34.1% in 2015-16 to 26.8% in 2016-17. Personnel emoluments or wages expenditure as a proportion of recurrent budget reduced from 75% in 2016-17 to 73% in 2017-18. So of course, challenges remain for financing health in Kenya. Aside from the stress from the COVID-19 pandemic has put on all counties. So at the national level, we see gaps between current status and 2030 targets for several indicators, including government health spending, access to care, financial protection, and maternal mortality ratio. Improving performance will require improving financing, efficient use of resources, continued focus on increasing demand and utilization of health services. The target of having 60% of the population covered under mandatory insurance by 2017 and over 85% by 2030 is ambitious and requires important reforms and governance at NHIF, as well as upfront investment at national and county levels. Effective health insurance coverage can help reduce financial and other demand-side barriers to care and may raise healthcare utilization, but success depends on NHFI's ability to enroll and subsidize the poor and vulnerable, as well as critical resources from national and county governments in preparing public health facilities to meet any future expansion in utilization of services. Kenya will also need to work toward integrating the various schemes to reduce fragmentation and more effectively pool risks, which will require harmonization and services covered under each scheme. As demand for health services grows and external financing declines, sustainability of health resources, especially for core disease programs, is becoming a critical challenge. And progress in decreasing household out-of-pocket expenditure is slow, and there is fear that economic shock imposed by COVID-19 may drive low-income and rural residents to incur more catastrophic health expenditures. At county level, we see that counties are too reliant on government direct transfers and a very limited ability to raise own resource revenue. Despite progress, counties still have much to do to enhance PFM systems and policies and make efficiency gains, more targeted use of limited resources. Public health facility autonomy to develop their own budget and retain their revenue remains a challenge, and supply of key commodities to counties remain a challenge. So while Kenya is administratively devolved, the county is not yet fully fiscally devolved, making it difficult to choose one level over the other is focusing health financing support. While counties need increasing support and investment in raising and managing health resources, key reforms in health financing will depend on political will and ability of national government to implement, to make health universally affordable, efficiently procured, and efficiently delivered. Investments in sustainability are required from both levels of the government. So it took a little longer. Thank you very much.
Thank you, Suneeta, so much. I think what we saw were some of the similar challenges and opportunities that our own research had shown. So thank you so much for that detailed readout on HP Plus's role. Now we're going to turn to Steve Rozner, who's a senior fiscal advisor at USAID. Steve?
Hello there, and I hope everyone can hear me. So thanks, Smita, and thanks to Suneeta for that great presentation, and to Andrew as well. I'll just dive in because I know we want to reserve as much time for conversation, but I'm going to speak just to some of the ways in which conversations about DRM and health financing are being shaped by the COVID pandemic, and try to relate some of this to the Kenya situation, which is not necessarily my subject matter expertise. I've worked in Kenya, but I'm not a Kenya hand, so to speak. But just to start off with, as we already know, the events of the past 18 months, they really underscore just how central DRM is, not only to achieving SDG 3 and its an important health targets, but also the country's overall ability to weather shocks and to avoid the kinds of development setbacks we've seen in so many parts of the world. We now know that countries that had greater fiscal space, that we like to speak of, before the pandemic, they were able to mount more aggressive public health responses and also provide financial relief to businesses and households that were really affected by the pandemic. And by contrast, the policy responses really were far smaller in countries that entered the crisis, with less fiscal space, with larger deficits, with higher debt burdens. And, Kenya certainly falls into that group. It spent less than 0.5% of GDP on its COVID response in 2020, and it will spend roughly the same amount in 2021, according to projections. So Kenya, like many other countries, it didn't invest in building the fiscal space it needed to respond to shocks of this magnitude before they happened. And the government it now finds itself with limited options to respond to the current crisis, let alone to sustain existing health services. And this is all at a time when those services are, arguably needed most. So for countries like Kenya, the reality, as most of you probably know, is that donor support is not going to fill these spending gaps over the long run. Many of our low-income country partners, they still depend heavily on external funding, on donor assistance to meet their health sector priorities, and they'll continue to do so likely well into the future. But middle-income countries like Kenya, they're in a more precarious position. In these countries, being middle-income, the demand for health spending continues to grow, and even as program support for health plateaus, or in some cases, is really declining in precipitous ways. And the spending gap is really, it's filled not by spending by local or national governments, but predominantly by out-of-pocket spending, which is a real concern. out-of-pocket spending by individuals and households, which, as we know, is both inefficient and regressive, and it also leaves households at risk of impoverishment and other hardships when catastrophic health events occur. So what's the solution to this health financing conundrum? And unfortunately, there's no easy answers, as we'll probably establish today. And I'm certainly not an expert on health or on UHC, and certainly not on Kenya, as I mentioned. So please take the remarks that follow as fodder for conversation, not as a prescription or even as an official USAID position, which they're not. That's my caveat. But first off, I believe that the path to UHC, I think it demands a multi-pronged strategy. There's a tendency among health system stakeholders often to spend a lot of energy and political capital on what they consider to be magic bullets. Let's do sin taxes. Let's set up a trust fund or leverage the private sector rather than consider a strategic mix of options. I've seen this, and relying on single options for financing health reduces the ability of health programs to smooth resource flows across the economic and political cycles of each option. For instance, think about this, earmarking revenues from a particular tax, say an airline levy to pay for HIV services. That's actually something that is done in some countries. It may produce good revenues when demand is high or markets are hot, but over-reliance on a single source can be devastating in a downturn. We need to be more strategic and see the whole chessboard in this respect. For instance, we could also be helping our government partners become more agile and responsive when crises emerge. When COVID-19 hit the Philippines, for example, USAID helped the government to identify $6 billion in approved budget allocations that, because of the pandemic, they could no longer be implemented as planned. So the government then was able to repurpose those funds for the pandemic response, and that was a real agile response. Likewise, in countries that might soon be candidates for debt relief, this is something that's a little bit out of left field. We can think about how potentially those debt write-offs could conceivably create the space to redirect funds to help fund healthcare priorities such as UHC. And that kind of debt for health result swap really requires good planning and execution, and that's yet another area where donors such as USAID could help. Now, people often ask me, well, what about the private sector? What about its role in mobilizing resources for health? I don't want to rain on that parade, but I'd urge caution in that regard. Well, there's lots to talk about the private sector. The reality is that governments will continue to have to do the heavy lifting when it comes to paying for UHC and reducing out-of-pocket spending. The private sector, sure, it may be perfectly willing to provide the services or to provide the loans and guarantees or insurance products that enable those services to be provided in the first place. But those private actors, ultimately, they need to get paid. And at the end of the day, those payments will either fall on one of two sources, either households or on governments. And of those two options, only really governments operate at the scale needed to mobilize the resources that are actually needed to sustain health systems and ensure that nobody falls through the cracks. Whether it's through broad-based or mandatory health insurance schemes, as Suneeta mentioned, or capital investments in new facilities and equipment, or other approaches. So, in that regard, I see a number of ways in which governments could be directing their efforts. Health system stakeholders often talk about increasing the size of the health sector's slice of the resource pie, about increasing health share of the budget through greater prioritization of health. And that's important, but prioritization alone is not going to get the job done. We also need to increase the overall size of the pie itself. And this is classic domestic resource mobilization. And this is what I work on day in and day out, improving tax policies, making them more equitable and simple, strengthening collection capacity, both at the national and subnational level, and ultimately expanding national and local own source revenues, and thereby creating the fiscal space that these national and local or county governments have to prioritize from. And we can point to many examples where USAID programming, in the DRM space has helped countries achieve both increases in, in revenue collections, and in turn, because of having that additional revenue, they were able to achieve sustained increases in health allocations. And again, we have the tools and expertise to help in this regard. Now, of course, higher allocations for health will not always translate into more actual health spending, which is why we need to focus simultaneously on improving the efficiency of existing health spending, as has already been discussed a bit. Improving spending efficiency is probably considered one of the most viable strategies for expanding resources available for health. And there's lots of room to realize cost savings, for example, in the deployment of health personnel, or to strengthen the management of health supply systems, or to be able to procure drugs and other health commodities in greater quantities and at lower prices. And of course, let's not forget, we also need to give greater attention to the timeliness and predictability of transfers from, to national to subnational governments. That's a really important area. And for the considerable, for the foreseeable future, I think that transfers are still going to be a fundamentally important part of the resource picture for subnational governments to work with. And this is really where improvements in budgeting, whether through program-based budgeting and participatory budgeting, and improved public financial management, or PFM, and also improvements in public oversight of the budget. These can be important complements to domestic resource mobilization strategies. And again, this is an area where USAID has a lot of experience, both specific to the health sector and more generally. Now, working on these efficiency challenges this is just the last thing I wanted to point out, it can also help health stakeholders address the problems of perceptions. And I remember, several years ago, the Kenyan Treasury Secretary once telling a room of health sector advocates, I happened to be there as a fly on the wall, that he would gladly have supported increased allocations for health if only health stakeholders would start spending the budgets he already gave them better. And this kind of sentiment is a common one, the perceived inefficiency of the health sector. And whether it's just perception or reality, that perception, that notion tends to make budget and finance stakeholders unwilling to consider plus-ups for health without being able to see or measure demonstrable improvements in health spending efficiency or in health results. So all this is to say that it's not enough to have budgets and policies passed. Health stakeholders at the national and subnational level need to improve their PFM practices to ensure that they get the resources budgeted, and that they spend them and account for them and demonstrate that they have been spent well. And donors such as USAID have a role to play in this exercise as well. In particular, we have tools and we have the convening capacity to help these health stakeholders build relationships outside of health, with the finance ministries and the tax authorities, with media and civil society actors, even with legislatures. And these relationships, I think, are critical for building the coalitions and framing the advocacy that health sector stakeholders need to advance the health financing agenda. And we may also, in this process, we may also need to invest in building the oversight and accountability capacity of some of these external partners, especially the media and civil society organizations, to participate in that budget process. And as Suneeta mentioned, to build the evidence base that we need to advocate and hold governments accountable for health services that citizens should reasonably expect. So I think this is a campaign that needs to be waged on multiple fronts, but I also believe it's a worthy one, and one that we should all be able to come together and find alignment on. So I'll stop there and pass it back to Suneeta and look forward to the conversation.
Thank you so much, Steve. I think you laid out a number of things to think about. And there were some great recommendations there. So I hope people took note and have started, thinking about your own response to the conversation so far. Now I'm going to turn it over to Anne Musuva, who's the ThinkWell Country Director for Kenya. Anne, over to you.
Thank you, Suneeta, and thank you to the previous presenters. So good morning, good afternoon, good evening. I'll present some reflections from Kenya on health financing at the subnational level with the context of devolution. Oops. Trying to press this, it doesn't seem to be moving forward. Perhaps, Julie, you could share the slides for me.
Sure, or you can try pressing the arrow button or enter.
That's what I'm trying to do, but seems to really have hung. Not sure why.
Oh, okay. I can share then. Let's see. Sorry, mine is also being a bit weird today. Just download that. Can you see this?
Works now. Yes.
Okay.
Thank you, Julie, and apologies for that delay.
No problem.
All right. So I'll just jump right in. So as has been discussed before, many low and middle income countries like Kenya are undertaking health financing reforms to make progress towards the goal of universal health coverage. And this is against a backdrop of devolved government systems. There is need to understand how devolution shapes specific design features and implementation of health financing functions. So in light of this, the WHO and ThinkWell jointly developed an analytical framework and implemented 7 country case studies. And this analytical framework seeks to understand how decentralization has shaped health financing arrangements and PFM practices at subnational level. So we are developing a synthesis report, which will be shared in due course. So in this presentation, I'll share my reflections on 3 key findings from this work using Kenya as an example. And I'll also draw on reflections from our county work on the strategic purchasing for primary healthcare project, which is a multi-country project implemented in 5 countries, with Kenya being one of the countries. And the goal is really to strengthen strategic purchasing at primary healthcare level. Next, please. So my first reflection is really on the importance of subnational, of intergovernmental transfers. Just start by painting a bit of the picture on subnational health financing in Kenya. And Andrew has already alluded to this. So over the past 2 decades, we've seen a significant increase in domestic general government health expenditure as a proportion of current health expenditure. So in the year 2000, government health expenditure as a proportion of current health expenditure was 29%, and this has increased to 43% in 2017. And we've seen a commensurate decline in out-of-pocket expenditure and also in donor expenditure in Kenya. Now, if you look at the graph, the other graph, we can also see, as has been mentioned earlier, that there has been an increase in government spending in Kenya. But I think what's important here to note is actually the fact that a lot of this spending is now occurring at county level or at subnational level as compared to the national level, which is what we had before devolution. And so counties are now controlling the majority of government health spending, and they're the main purchasers of primary and secondary care in Kenya. Next, please. So where is this where is the county budget or revenue coming from? So the bulk of spending at county level is coming from the national government. So basically, counties are relying extensively on transfers from the national government. And the bulk of these funds are structured as a block grant that we call the equitable share here in Kenya. In addition to this, the national government has also been using conditional grants to transfer more earmarked resources for the health sector to county. And these have been earmarked for primary health care, for reproductive, maternal, neonatal, and child health services. The second main source of revenue for the counties is own source revenue, which constitutes 11%. But obviously, this is a very small proportion compared to what counties are getting from the national government. So from equitable share and from other conditional grants from the national government and from donors. In the current financial year, some of these conditional grants earmarked for certain health services are being discontinued and are instead being put into the equitable share. And what this means then is that counties have much more discretion over how these funds are going to be spent. And the main question and concern for stakeholders is, will this increased equitable share at county level, will this
And it sounds like you're breaking up a little bit.
And do you want to try turning your video? Yes, because I think your bandwidth, I think, might be a little.
The health sector. And it will therefore be out to help their any disease. I hope this is better.
Yes, try to keep going.
All right. And so I was just saying that the county health allocation varies considerably between counties, ranging all the way from 15 to 35% in the financial year 18-19. And so the concerns are that the gains that have been made with the conditional grants may be eroded if counties don't really allocate these additional funds coming into the equitable share to health. They really have the discretion to allocate these to any sector at the county level. Next, please. And so this comes to my next reflection on the need to really optimize the opportunities for revenue raising at county level. And I'll pick on an example on NHIF. Now, in the last financial year, NHIF paid out approximately $600 million to health providers in Kenya. And this was to both the public and the private providers. And only about 30% of these funds went to public facilities. Yet about 50% of facilities in Kenya are public facilities and offer about half of those services. One of the NHIF schemes that was mentioned earlier by Suneeta, I believe, is the Linda Mama scheme for free maternity services. And as part of our work, we've actually carried out some work in 3 counties in Kenya, just looking at how are counties participating in this Linda Mama scheme, in this free maternity scheme. This is a scheme where all Kenyan women are eligible to participate as long as you're pregnant. And facilities are reimbursed for services provided. So these are, for example, delivery services, antenatal and postnatal care. And what we realized in these 2 counties is that counties, for example, in County A in 2018-19, the county had the potential to raise 149 million Kenya shillings. So that's about $1 million, $1.5 million from NHIF specifically for the Linda Mama scheme, but only raised about 55 million Kenya shillings. And so working with the county to increase this revenue from NHIF, we're able to triple that from 55 million shillings to 155 million shillings. And in the other county, from 32 to 71 million shillings. So counties really have the opportunity to increase the revenue into the county health system by strengthening facility autonomy and enabling all public facilities to submit claims and track these payments on a regular basis. This is increasingly important as Kenya's UHC plan centers around scaling up NHIF. And therefore, public facilities need to be able to fully participate in NHIF. Next, please. And so in light of all these additional funds at subnational level, tracking resource spending at subnational level is increasingly important. We have a lot of resource tracking tools and frameworks and data and so on, but it's still increasingly difficult to get a sense of the average resource flows to facility level at your average health facility in Kenya, you know? And I'm talking about, for example, how much revenue is generated by public facilities from user fees, from NHIF reimbursements. How much are they getting from counties in terms of direct transfers? How much is coming in terms of supply side financing? Just the same way we have a district health information system platform where you can actually drill down and see service delivery statistics at facility level. I envision something like that for healthcare financing at facility level in Kenya. There's certainly the need for much more transparency on resource flows and expenditure at facility level. And this picture basically just shows the flow of funds, some work that was done by ThinkWell and colleagues from Kemri Wellcome Trust on the flow of funds in counties. And what we see is that counties are really turning into labs of direct facility financing experimentation. So just very different arrangements across different counties and also at different levels of health facilities. Next, please. And so in conclusion, I think you'll all agree with me that strengthening health financing at the subnational level, particularly revenue raising and also strategic purchasing, is critical to ensure that there's more investment in health, but also more health for the investments that we're making. And has been alluding, and you've seen all the work that HP Plus has done, and also in building sound PFM policies at subnational level. But there's certainly much more work that needs to be done. The recommendations from the report that Andrew has shared are really timely and actionable in terms of giving facilities the autonomy to raise and retain the revenue generated at facility level to improve service delivery. And all this will be important to decrease wastage and improve value for money. Thank you.
Thank you so much to Suneeta, Steve, and Anne, and also Andrew before that. The presentations, I think, were really in depth, and I think we heard some common challenges. The common challenges that I heard throughout was lack of autonomy by the county governments. We've heard a lot of challenges in government transfers of resources. We also heard not having good fiscal policies in place. I think Steve mentioned the challenge of that when it came to being prepared to address pandemic threats like COVID. But we also saw that there was a lot of great work being done at counties, and there was increase in financing for health at national and subnational level. Steve gave some, solutions, not one-off solutions, but some longer-term solutions that could help. So I think the question we had for our participants is, what thoughts do you have on taking the best practices and lessons learned to date, what we heard during this hour, during this presentation, but also from your own experiences and in your own, work in this area of how this can be sustained? What can USAID do? Steve talked a little bit about what he thought USAID could do, but what could donors like USAID, how can they work more effectively with country governments to improve national and subnational resource mobilization, particularly in the area of health? and also in the area of public participation in budget planning and implementation. So with that, and just to keep in mind, one of the things that we're really interested in is as we look to, we have less than a decade to achieve the SDGs, particularly the SDGs for health. So what can we do now in light of the pandemic? Of course, that has, so just wanted to open it up. You can put your comments and questions in the chat box, or just, you know, jump in. When you do, if you do intervene, please just introduce your name and where you're from, since we really didn't do introductions. And if everyone wants to go off camera so we can see each other, you're welcome to do so. None at all?
I have a question, Suneeta, if that's okay.
Yes, please.
Thanks so much. And thanks for this lively and interesting discussion. I just wanted to ask a little bit about this issue of social health insurance. And so a bunch of global experts, health financing experts last year restated their concern about low and middle income countries pursuing social health insurance as a way to bring more revenue into the health sector, and the lure of, you know, collecting more contributions from the population is what drives many ministries of health to pursue this strategy. But in effect, in country after country, we see that that's hard to realize. And so the case was restated by some of these global experts, and yet we see in many African countries, this is the strategy that the country governments are pursuing. And indeed in Kenya, the approach that the government has been pursuing for a while focused on scaling up NHIF, and this was reaffirmed in the UHC scale-up plans last year, which is now being implemented this year. But NHIF has struggled to realize this dream of enrolling informal sector households for many decades now. And so I wondered if, Suneeta, you could offer some reflections from HP Plus's experience and your perspective on this question. HP Plus has been involved in the health financing strategy development in Kenya for a while now. And what are you seeing as new thinking that at this point could give us hope that this NHIF-based UHC approach could actually bear fruit? And I also wondered, Steve, from your perspective, are there, you know, notwithstanding some of these broader concerns, are there tax strategies that you've seen countries using successfully to actually realize this kind of ambition? Are there approaches that would allow Kenya to collect mandatory contributions from the informal sector, which in practice end up being voluntary contributions? Apologies for that long-winded question. Thanks.
Great, thank you, Nirmala. I'm gonna, Toril, I had on my list to turn to you anyway, but let's hear from Suneeta and Steve first, and then I'll come to you.
Okay, thank you, Nirmala, great to see you. Yes, so as you know, NHIF, like it can play a really important role, but there's so many like NHIF reforms are needed. We need to improve efficiency. There's so much like governance side work needs to be done to prepare and then really scale up. So this is something we need to work on, which is not, you know, always when we talk about these technical analyses, they're good, but political economy of it, really understanding political landscape, different players, and then how you balance it. That is something NHFA is not easy, but that is something can really help overall improvement in efficiency and governance be good. And informal sector, as you know, it has been a challenge. So many countries are struggling with it. And also it is not something we can say that social insurance can cover everyone and cover all the benefits and all. It has to be really starting from selected, like really thinking about the poor. We are saying that that's really important, and benefit package that we can afford. So all of those things are really all those trade-offs and understanding what countries can afford, what can be done. So that's how it is. And always people also talk about that it's not just always, one, like depending too much on insurance. You also need to think about multiple ways, and even private sector has some role to play. But I fully agree with this, Steve, like it's not that it's still a scale up and the big responsibility of the government. It's not you can depend on private sector to put in a lot of money, but there's some discussion about blended financing approach as well, but that is very little of overall what we need. So that is what I would offer, but there we can have more discussion. I just want to keep it short at this point.
Yeah, I'll just add to that. I fully agree. In terms of, that your question, it goes back to the point I was making about cautioning against looking for magic bullets to single responses and looking at holistic strategies. You look at a country like Thailand, which used a tax financed, general taxation financed approach to funding its national health insurance scheme, and it has achieved UHC. And I think that was one approach. But then you have a country like the Philippines, where it's making a lot of headway in terms of getting closer to UHC by using a very mixed approach. They've done sin tax reforms that have brought a lot of revenue from tobacco and alcohol taxation into the system. But that's not the only thing that's financing the system. They've got other ways of approaching it as well that look at all of their revenue tools, all of their financing tools, including borrowing and other things like that. But you have to look at sort of the whole, as I said, the whole chessboard when you're thinking about these things. And so I don't have there's no like perfect tax for this situation, but there are strategic ways to go about it.
Thank you for that. Toril is from NORAD. So in addition to whatever you're planning on intervening on, I would also love to hear your own country's experience, who's been very engaged with DRM.
Thank you. Yeah, the comments and questions might be mixed up in that sense. But thank you so much. Very interesting presentations. And it's interesting, yesterday we had a meeting with a global partnership for education, also looking at, how to use more dialogue with health sector expertise and how to mobilize more resources for those social services. So, what I've been thinking is there a way that we can bring these different sector actors and advocates together? Because we know that there is a need for a much more strategic approach and dialogue. If you grow the tax revenues at the national level, more is going to be available also for health sector and education. And we know that there's not a competition between these, but sometimes in national negotiations around budgets, it can appear that way. So if there is a way to think about national alliances around strategic advocacy for tax policy, I think that would be very interesting to explore in the next year around the financing for development. We've seen little of it, and that's something that we'd be very interested in supporting going forward. I also think that the way that health sector advocates and actors have a very strong standing within government and in regional organizations as well, and looking at adding the voices to more strategic challenges with revenue losses from governments, for instance, through illicit financial flows, seeing how these linkages are very much related to national funding for health sector services. If trillions of dollars are leaving developing countries' public budgets through illicit financial flows, of course, has a direct impact on national funding for health services. And we've been also supporting from NORAD's side to try to elevate the focus on the subnational taxes. And there is significant potential here, particularly in property tax, where we see that developing countries have a huge potential or untapped potential that can be challenging for some local authorities to bring forward because it can be politically sensitive, but supporting local governments in making an advocacy point, tying this to the services or health service in particular, can both help local governments advance the social contract, improve the revenues, and then improve the services. And this is something that health sector actors, advocates, and civil society are better placed than some of us in the tax justice or DRM space, right? Because you have a credibility in terms of talking about the need for the services. So I think in general, using the position of the health sector organizations, advocates, and specialists to engage in a more strategic dialogue and discussions with governments when it comes to DRM and tax policy would be very welcome. And I think that's something that can really, unpack some of the locked up potential here. We know that there are resources out there that can be channeled, but I think we're not managing to do it because we have still a very fragmented approach, looking at one tax type at a time, one sector at a time. So that's something that I would be very interested in engaging in going forward. Thanks.
Thank you so much. We have a hand raised. Arturo has a question, but any quick responses to Toral's?
Yeah, just this is really an excellent point. Just Guatemala comes to mind when we talk. We have really good civil society organizations. They're also really looking at implementation, monitoring policy, and allocation of resources. So for example, they have earmark tax for alcohol, which is 15%. And civil society engagement is really making sure those resources are allocated and used for the purpose, why they are like this for family planning. And they have very good, as you mentioned, it's not just one sector. There's an information system for 17 different departments, all social sector, really looking at total transparency in terms of allocation of resources, monitoring policies, and that system has access from President of Guatemala to indigenous women in Guatemala who can use the system, ask questions, and also link to apps and everything, like fully digitized. So those kinds of things can make a big difference, as you mentioned.
Great.
Yeah, I'll just add to that. I mean, Toral, you're absolutely right. Your first point. We like to say that domestic resource mobilization, taxation and revenues is the rising tide that lifts all boats. So it's still sort of perplexes me that we can't get health sector stakeholders and education sector stakeholders and environmental stakeholders on board with this idea that, you know, the government's ability to collect taxes subnational level, national level is also their business. We want to sort of build that type of coalition, those alliances, so that they're also clamoring for better taxation, not just for more resources for my sector or my interest. So I would love to see that happen. And if you have any ideas about how to make it happen, let's talk offline.
Arturo, I know you have a question.
Yes, so I'm very interested in hearing more about Steve's point on trying to improve the social perception of subnational health systems. I think that DRM depends on people believing in the system in order for them wanting to invest in it. We need governments, we need the private sector to believe in the system in order to buy into it. And so from a communication standpoint, from a just public perception, how can donors support those systems to be better perceived, to break that vicious cycle of underperformance justifying underfunding and underfunding justifying underperformance moving forward?
Wow, that's the $1 million, the $1 billion question. So thanks for that. I don't have an easy answer, and I know that we're running short on time. But you know, there's been a lot of evidence out there that governments need to be doing more to be able to demonstrate to citizens and to their constituents that paying taxes is comes with real benefits. And I think that we as donors have an opportunity to help not just forge more dialogue. Dialogue is important, but to actually help our government partners to build the capacity to be able to do the outreach with taxpayers, to be able to provide the assistance needed, to provide information on why people are paying taxes, because that's just a starting point for getting people into the room and asking the questions. Oftentimes people don't know what governments are spending money on. They're delivering services, but people don't necessarily tangibly see and feel them. So I think we need to be doing more work in that area and helping to build that tax morale, that intrinsic willingness for people to pay because they see that there's some value in it. So that's all I have to say at this moment. It's a longer conversation, but thanks for the question.
I know we're running out of time, but there's a great question from John at IBP. And John, I wonder if you'd like to just ask your question. It was in the chat box. Which was, how much do we understand of the challenges, and are we directing our resources to areas that can solve the issues of, poor execution at the subnational level? But also, and then the second part of this question was based on the studies presented today. What is the space for public participation to improve the health outcome of budget engagements in tracking what happens after budgets are approved? So thank you, John, for that question.
Yeah, I can just respond briefly. Like HP+, we have been working on tracking resource use, and as I mentioned, absorption rate, because that's really important. It's not just enough to allocate resources, but how much they are used for the purpose. So it has improved, as I mentioned, from 73% to 84%. So we are continuously doing it. I think that's a very important aspect of it, the tracking resources. And for that, really, this national health accounts, subnational health accounts, expenditure reviews, all of those things, as they should be institutionalized, should become part of the system where you can really look at how it is done. And if something needs to change, improve governance, improve efficiency, as well as program-based budgeting, I think brings closer to PBB, brings closer to linking to outcomes. Like, it's still not there, but at least we are able to link inputs to programs.
Just one quick thing to add in addition to Suneeta. I think there are good efforts that have been made to track expenditure at national and subnational level, specifically at county level in Kenya. But I think there are still efforts. There's still much more that needs to be done. to track this at facility level, and especially with increasing expenditure going to the subnational level. So I think that's still quite a gap that we still need to work on.
Thank you so much. I know, as it always happens, we have such great discussion that happens towards the end of the panel and events like these. But Save the Children is going to continue to engage in this discussion. You know, our work in Kenya is continuing. We're also trying to increase the focus on this. Particularly, I know we had a representative from USAID Global Health, and I'm sorry we didn't get to you, but one of the things that most immediately we're looking at is how, you know, as we look into the next phase of USAID's approach to ending preventable child and maternal deaths, and looking ahead to the 10th anniversary of the Child Survival Call to Action event next summer, or thereafter, we're working with colleagues on when that might be, but looking at how this piece of work, right, USAID's role in fostering and looking at the challenges and addressing the challenges of subnational financing for health is part of the ongoing partnership between USAID and its priority countries in MNCH, but also broader. I have a specific interest in MNCH, which is why I'm narrowing it to that, but it is not limited to that. And Steve, I know my colleagues are going to continue to have conversations with you on this topic more broadly, and hopefully we'll have more roundtable discussions like this. So thank you so much for everyone's participation. And again, many thanks to our panelists and Suneeta, Steve, and Andrew.
Thank you.
Thank you.
Thank you.
Everyone.